Hello and welcome everyone to this session on case-based scenarios quiz mixed bag. My name is Dr. Jhanvi. I am the anesthesia educator on Unacademy, and today we will be discussing some case-based scenarios from all subjects. It will be a good revision for us because all of you all are now going to be preparing for your NEET PG, so it's the last leg of your preparation. So I hope that all of you all know the answers to these questions. So let's have a look at some of the clinical case scenarios because those are the common things that come in your exam. So I am a gold medalist in anesthesiology, and this is the Telegram channel Let's Crack NEET PG, where you will get all the links to the classes that I take. And this is the NEET PG free test calendar for March. As you guys can see, on 28, 29, 30, 31st March, every day we have free grand tests available for you all. So today's test was at 7 p.m. by Dr. Nikita Nanwani, and we also are launching the previous year question bank on 23rd of March 2022. A dedicated section for previous year's questions was launched, so you can use this for your NEET PG, INI CET as well as FMG preparation. And Unacademy Lite is one of the new offerings of Unacademy, in which you get the NEET PG test series, and also this is the end of year sale that we are having right now from March 28 to March 31st. So you can get an additional 20% off on your Plus and Iconic subscriptions, and for getting this offer you can use my code Dr. Jhanvi Life. Now along with it we are launching the MBBS Prof 1 course. So we are going to teach you how to answer everything in clinical integrated manner, and also how to write your answers in the final year MBBS exams. And we also have a doubt clarification series for subject wise doubt resolution sessions from April 6 onwards with top educators. And the Plus subscription on Unacademy, as all of you all know, will help you learn from India's top educators, compete in live tests and quizzes, study on the device of your choice, and access question bank with 25,000 plus questions. The Iconic subscription between Unacademy and Prep Ladder will help you get the best of both Unacademy as well as Prep Ladder, and these are our FMG December 2021 toppers. So remember, if any of you all want to join any of the Unacademy Plus courses or Iconic courses, we are running the end of the year sale, and you can use my code to get this discount. So with this, let's begin our class for today. This is the NEET PG High Yield Theory Revision batch which is going on right now, and also the NEET PG High Yield Revision and MCQ batch is going on right now. So the first question that I have for you guys is, while doing an esophagogastroduodenoscopy to check if he has varices, a patient gets a large bout of hematemesis. Blood is transfused to restore his hemoglobin. What else should be given in this case? Erythropoietin injection, random donor platelets, single donor platelets, or fresh frozen plasma. What should be given to this patient? Hello, good evening KGB. Can you tell me the answer to this question? Okay, so Chakravarti, KGB, Sonal are saying option as D, fresh frozen plasma. So what is the problem that you see in this patient? You are doing an esophagogastroduodenoscopy to check if he has esophageal varices, correct? So in case of esophageal varices, what is the underlying condition? Anyone, what is the underlying condition in case of esophageal varices? Most of the times it is because of portal hypertension. This portal hypertension is because it secondary to liver cirrhosis, correct? So if there is any kind of liver damage, alcoholic liver disease, anything causing a decline in the function of the liver, what is going to get affected? You are going to have your albumin production low, you are going to have your detoxification function low, but very very important in that is your coagulation factors will be low. Okay, and specifically which coagulation factors are we talking about? Anyone? What are the specific coagulation factors that we are talking about over here that the liver produces? Yes, Sonal, tell us. Yes, so your factor 2, 7, 9, 10, they are your vitamin K dependent coagulation factors. correct? Vitamin K dependent coagulation factors, factors 2, 7, 9, 10. So these are the ones that are depleted. So as a result of this, you need to restore these factors. Now how do you restore these factors? You can restore them by giving fresh frozen plasma. So when the patient is having a large bout of hematemesis, yes, you have to give him blood to restore his hemoglobin. But to stop the bleeding in this patient, you also have to give fresh frozen plasma in them. Alright. So that is the answer for our question. Absolutely correct. Okay. What is the procedure that should be done during esophagogastroduodenoscopy to permanently stop the variceal bleeding? Endoscopic sclerotherapy, endoscopic balloon tamponade, endoscopic cauterization of varices, or endoscopic band ligation? What is the procedure that should be done to permanently stop the bleeding? Anyone? Okay, KGB, Chakravarti are saying band ligation. Alright, so if I give you two options, instead of giving you one option, if I say you can do two best procedures to stop the variceal bleeding permanently, not a temporary procedure, to stop the variceal bleeding permanently, I am giving you two options. What will your answer be? Yes, absolutely correct. Endoscopic band ligation is one of the procedures. What is the other one? To permanently stop the bleeding. Yes, very good, Sapna. The other one is sclerotherapy. Okay. Now remember, cauterization of varices cannot be done. It will not stop the bleeding. Balloon tamponade, or the tube that we use, the Sengstaken Blakemore tube, that is the one that we use for balloon tamponade. Sengstaken Blakemore tube in case of hematemesis. This is a temporary method for stopping the bleeding. So if you want permanent method for stopping the bleeding, you have endoscopic sclerotherapy and endoscopic band ligation. And out of the two, which is the better method? Out of the two, the better method is endoscopic band ligation. Okay. So this is a permanent and more reliable method. So that will be our answer to stop the variceal bleeding. Alright. A 40-year-old female comes with a large neck swelling. On clinical history and examination, she complains of dyspnea on lying down, hoarseness of voice since 2 months. On palpation, the lower border of the swelling is not filled. What will be the test to evaluate the extent of this mass? X-ray chest, CT neck and thorax, USG neck, or FNAC of the mass? Okay, very good. So Meena and Sonal are saying X-ray chest. Anyone else? Any other answers? Anjana is saying she'll do a CT neck and thorax. Now look at the question that they are asking you. They are very specific in the last line. They don't want to know what is the diagnosis. They want to know the test to evaluate the extent of this mass. So where do you think is this mass arising from? It's in the front of the neck and it is causing dyspnea and hoarseness of voice. Where is the mass arising from and why is it causing dyspnea and hoarseness of voice? Can anyone tell me that? Yes, so it is a thyroid swelling, absolutely correct. And why is it causing dyspnea on lying down and hoarseness of voice? Because there is compression. Where is the compression? Compression on the trachea is causing dyspnea and compression on the recurrent laryngeal nerve is causing hoarseness of voice. Alright. So because of these two things and the thyroid swelling, we are having a problem with the mass. Now when they say that you cannot evaluate the lower border of the swelling or you cannot feel the lower border of the swelling, that means it is extending behind the sternum. Barabar? So this mass is going retrosternal. This one particular line that is there, this is very, very characteristic of a retrosternal goiter. So this is a retrosternal goiter. So retrosternal goiter mein, how do you evaluate the mass? You evaluate the mass by doing a CT neck and thorax. So the CT neck and thorax will tell you exactly how deep is your mass going inside. Okay. Alright, everyone understood? Okay, so what is this test that we do in retrosternal goiter? You ask the patient to raise both the hands above her head and the patient looks like this. What is this sign called? Graves sign, Geoffroy sign, von Graff sign, or Pemberton sign? Okay, Sapna is saying this is Pemberton sign. Any other answers? KGB is saying Pemberton sign, Pemberton sign. Okay, everyone is saying Pemberton sign. Alright, absolutely correct. All of you are right. This is called as Pemberton sign. Okay, now tell me what is the side effect of Pemberton sign? What is the side effect of Pemberton sign? Is it safe for me to do the Pemberton sign? And if yes, why? If no, why? You all are right. D is the correct answer. But tell me, can I generally do Pemberton sign in the OPD? Okay, so remember it is not safe to do the Pemberton sign in the OPD. Okay, why? Why is it not safe to do the Pemberton sign in the OPD? So when you ask the patient to raise his hands up, this is a patient who is having a retrosternal goiter. So the thyroid swelling will move up and it will compress upon the thoracic inlet. So when it compresses on the thoracic inlet, all your venous return that is there will get affected. Okay, so when your venous return gets affected, you will have venous congestion. So can you see the face of this patient has become large, swollen and completely cyanosed? So this is because of the venous congestion. Okay, so this is because of the venous congestion caused by putting your hands up and causing the mass to obstruct the thoracic inlet. Now this can even lead to syncope in the patient. So this can lead to a syncopal attack because the blood will not flow through the carotids. The jugular will not drain and the carotids will not be able to push the blood to the brain. So this can lead to syncope in the OPD, and as a result of this you should not be doing this on an outpatient basis. So this is called as Pemberton sign, used for identifying retrosternal goiter. Alright, next question. Now suppose this patient is taken up for surgery. Alright, so retrosternal goiter you took for surgery. Immediately post thyroidectomy, the patient starts complaining of difficulty in breathing with a fall in saturation. So look at the timeline. This is happening immediately post thyroidectomy. The surgeon says patient had hoarse voice post extubation. What should the recovery resident do? Open the neck wound, do an indirect laryngoscopy, re-intubate, all of the above. I am giving you two other options. Both A and C, or both B and C. So you have 6 options. Tell me what will you do out of all these 6 options and why? Okay, so open and re-intubate is what Chakravarti is saying. Anyone else? Any other answers? KGB is saying E, all of the above, both A and C. Alright, so most of you have answered incorrectly. Most of you are saying that it is primary hemorrhage causing compression. But look at what they are saying. What about this part? The patient had hoarse voice post extubation. Why should the patient have hoarse voice post extubation? Is this giving you some kind of clue? Is this giving you some kind of clue as in what is wrong? Alright, so the fall in saturation is happening, yes. So one of the things that you have to do is re-intubate. So that I agree with you guys. Re-intubation has to be done. But this should tell you what is the problem. The problem is that you have caused a recurrent laryngeal nerve palsy. And how do you cause a recurrent laryngeal nerve palsy? By injuring the recurrent laryngeal nerve. Okay. So when you injure the recurrent laryngeal nerve, if this is your thyroid, your recurrent laryngeal nerve is very, very close to the thyroid. So when you're trying to remove the thyroid, at that time you cause a nerve injury. So nerve injury can cause the vocal cord on that side to get paralysis, and that's why the patient is having hoarse voice and not able to breathe very well. So you re-intubate the patient, you start the patient of steroids, hopefully the RLN injury will improve and your patient will be able to breathe. So how will you diagnose whether there is an RLN injury? So for recurrent laryngeal nerve injury, you have to do an indirect laryngoscopy with the ideal mirror and check whether the cord on that side is moving or not, and you will re-intubate the patient. So your answer is F, both B and C. Alright, so that is how you come up with this answer. Okay, moving on to our next question. Now this patient, everything has been settled post-operatively. Now you have decided that you will send her home. So after you send the patient home, after total thyroidectomy, patient comes home after 48 hours. He starts complaining of perioral tingling numbness. What should be given to correct this? Magnesium, potassium, calcium, both A and C. And tell me why. What should be given and why? Okay, so most of you are saying calcium should be given. Can you tell me why should calcium be given? After total thyroidectomy, what happens that after 48 hours you have to give calcium in the patient? Yes, very good, Chakravarti. Excellent. So when we are removing the thyroid, we are doing a total thyroidectomy. So the thyroid has 4 parathyroids also in it. Okay. What do these parathyroids produce? They produce parathormone. Okay. And this parathormone is responsible for increasing your serum calcium levels. So when it tries to increase your serum calcium levels, what happens when you remove the thyroid as well as the parathyroids? There will be a fall in your serum calcium levels, correct? Now, it takes, the half-life of this parathormone is 48 hours. That's why it takes 2 days after the parathyroids are removed for the calcium levels to go down. So on the day of surgery, whatever parathormone was produced, after 2 days it will disappear. And then there will be hypocalcemia and the patient will start presenting with signs of hypocalcemia like tetany, Schwastek sign, Trousseau sign, all of them. Okay. So you have to give the patient calcium in that case. Okay, absolutely correct. Alright, next question. A 62-year-old man with type 2 diabetes is posted for elective colonic resection surgery. He is on OHAs and insulin to control his sugars. What should be given on the day of surgery? Only OHAs, only insulin, both can be given, or both should be omitted? Okay, so I am seeing that there are all different kinds of answers. On the day, if someone is saying give only insulin, someone is saying both should be omitted. Purva is saying both should be omitted. The most of you are saying only insulin should be given. Okay guys, tell me, why should insulin be given in these patients? He is a type 2 diabetic patient, correct? And he has an elective colonic resection surgery. Why would you want to give? Any reason why you would want to give? Okay, remember, on the day of surgery, what is the state of the patient? Patient is fasting. Okay, so if my patient is fasting on the day of surgery, then he is going to have low sugar levels. So if I give OHAs or insulin in this patient, fasting plus OHAs and insulin, this patient is going to go into severe hypoglycemia. Okay, patient is going to go into severe hypoglycemia. So I don't want to give the patient severe hypoglycemia. So on the day of surgery, it be OHAs or may it be insulin, it has to be omitted. So if you are asked a simple question like this, your answer also has to be simple, that both should be omitted. But if you are asked a complicated question, what do you mean by a complicated question? For INI CET, this is very important. Sometimes in INI CET, they will say very specifically that patient has uncontrolled sugars and you have to continue insulin. The endocrinologist has said you have to continue insulin on the day of surgery. Then how much insulin do you continue? So here you have type 1 and type 2 diabetic. So in a type 1 diabetic, you will give half of the normal insulin dose on the morning of surgery, and in a type 2 diabetic, you will give 1/3 of the normal insulin dose on the morning of surgery. Okay, this is if they specifically tell you that insulin has to be continued, so how much dose will you give? But if they don't specify anything, they simply ask you what should be given on the day of surgery, just omit both of them. So Chakravarti is saying, ma'am, patient will go into hyperglycemia, but the patient is fasting, right? He is not eaten anything, so how will he go into hyperglycemia? It's only when you eat food that there can be chances of your sugars going haywire. So since he is already fasting, most of the times the patient's sugar will be under control. Alright? Okay. Now, post-operatively, the patient is asked to be nil by mouth for 48 hours. His HGT is 400. How should his sugars be managed? So what is the deal with this patient? Now this patient surgery is done and he is asked to not eat anything for 48 hours. And his HGT is 400. Now definitely you have to do something, correct? You have to take care of this big HGT. So how do you manage this HGT? Anyone? Definitely you can't just leave the HGT just like that. Post-operatively, if your HGT is on the higher side, then because of high blood glucose levels, you can get a lot of surgical site infection. So you want to avoid this condition and you want to bring his sugars under control. So what will you do? Subcutaneous insulin as per sliding scale, IV insulin infusion, OHAs, or as he is NBM, nothing is required. Chakravarti, that is a very good question that you are asking, but remember in the exam, don't assume anything. Whatever they are telling you, whatever is written in the question paper, you go by it. If they are telling you कि नहीं हमको insulin continue करना है, then you continue insulin at a lower dose. But if they are not telling you anything else, don't assume that since patient is on both OHAs and insulin, he must be having uncontrolled sugars. Okay, so Preeta, Chandrakanta, both are saying answer is B, IV insulin infusion. Any other answers? And why? Preeta, Chandrakanta, why would you want to give insulin infusion? Why not just give subcutaneous insulin or give insulin as per sliding scale? सो पूर्वा थॉट अरे ये लोग दोनों ने बी बोला है तो मैं ये बोल देती हूँ, शायद वो सही आंसर होगा. ओके, सो लेट्स लुक एट दिस पेशेंट. अगेन दिस पेशेंट इज नॉट गोइंग टू बी ईटिंग एनीथिंग. नाउ व्हाट इज माय कंसर्न? इफ आई गिव इंसुलिन टू दिस पेशेंट and he is going to be NPO, okay, then this patient can go into hypoglycemia. Correct? But if I don't give insulin to this patient, it's not right, because already his sugars are uncontrolled. So what is the best way to manage this? Now when I give subcutaneous insulin to the patient, it's a one-time dose, and I don't know how much will be the absorption from the subcutaneous plane, because I don't know the blood flow of that area. So it will be very varied. So suppose I give 10 units of insulin to the patient, and after 1 hour when I come, the patient has gone into hypoglycemia, because it is a variable absorption. Correct? Don't give anything as he is NBM, but despite being NBM, already sugars are high. Why is his sugar high? Because of post-operative stress. Post-op, there will be stress in the body, there will be production of endogenous steroids and increase in sugars. Should I give OHAs? Again, OHAs is oral route, so that is also varied absorption, so you don't know how much the sugar will go down. So my best answer over here is IV insulin infusion. So I start a continuous infusion of insulin, and I check the HGT every hour. So when I check the HGT every hour, I know very well that this hour it is 120, next hour if it comes a little higher, 200 say, then I'll increase my insulin infusion dose. If it comes 300, I will further increase my insulin infusion dose. If it comes 100, I will reduce my insulin infusion dose. So since it's a continuous infusion, I can easily titrate the infusion. Easily titrate. So easy titration can be done in this case. Alright. So that's how I manage my sugars. Okay. Now next question for you guys. This is an X-ray post central line insertion in the emergency room. What is the next step in this patient? Start vasopressors and medications through the central line, reinsert the central line, insert needle in 5th intercostal space, or withdraw and reposition the central line. So this is your picture that you need to see in the X-ray, and this is the condition. So again, see the picture, have a good look at it, and then tell me what will you do. What will you do? How will you proceed with this patient? Okay, so Yogesh KGB, Chandrakanta Yogesh KGB are saying you will start vasopressors medications, and Chandrakanta is saying you will put needle in the 5th intercostal space. Okay, now let's have a look at each of the options. Reinsert the central line if it is in the wrong space. It is in wrong place. Okay. Insert needle in 5th intercostal space. This you will do if there is pneumothorax. Withdraw and reposition the line again if it is in wrong place. And you will start the vasopressors medications through the central line if it is correct position. Barabar? Now let's look at our central line on the X-ray. So as you can see, the central line is coming from here. It is going into the IJV. From the IJV, it is entering into the right atrium, and the tip of the central line is at the SVC and RA junction. Okay, so this is your superior vena cava and right atrium junction. That is the tip of your central line. This side you can see the markings of the lung. These are your bronchial markings. This side also you can see. So definitely there is no pneumothorax, and the central line is in the correct position. So option B, C and D are wrong. Your correct answer is option A. So you will start the vasopressors medications through the central line in this case. Alright. So this is your answer for the question. Alright. So going on to our next question. An anesthesia resident has been asked to give this position for her patient to make intubation easier. In patients undergoing which kind of surgery is this position most commonly given? Oncologic surgeries, neurosurgeries, head and neck surgery, or bariatric surgery? Alright, so can you tell me what is the name of this position? Yes, absolutely correct. This is the ramp position. Right, this is the ramp position. So what is the ramp position? Ramp position is basically you make a ramp means a slope. Okay, you make a slope below the patient's head. Now in this you are making a slope in such a way that the tragus of the ear and the sternal notch, both of them are in the same line. Okay, so if the tragus and the sternal notch are in the same line, this makes your intubation easier. So ramp surgery is used whenever we have obese patients. Now, where do we usually find obese patients? Obese patients are usually found in bariatric surgery. So that is your answer. Okay, bariatric surgery means surgeries to reduce weight. So that is why that is your answer. Remember, in normal patients, what is the intubation position given? It is called as sniffing the morning air, or it is also called as barking dog position. This is the intubation position given in normal patients. Alright? Okay, moving on to our next slide. If this patient had to be put on a respiratory machine post-operatively to maintain saturation, which one would you prefer? A, B, C, D. So this obese patient is there and his surgery is done, and now you want to put him on a respiratory machine post-op. So which one would you prefer out of all of these four? Okay, so now I want you guys to tell me each of these machines and their names. What is A, what is B, what is C, what is D? The patient is this, his weight is 110 kg, and we want to put him on a respiratory machine to maintain saturation. Yes, tell me what are each of these images. Okay, so the first machine that we can see over here is called as the CPAP machine, or it is also called as the BiPAP machine. Okay, CPAP machine or BiPAP machine. So this machine is continuous positive airway pressure or bi-level positive airway pressure machine. It maintains a continuous positive airway onto the patient's airway, onto the patient's obstructed area, and it helps in increasing the decreasing the resistance to flow of air through the air passage. Okay, B is nothing but your nasal cannula, normal nasal cannula that we use in patients. C is nothing but your Hudson mask, and D is your non-rebreathing mask. Okay, now in obese patients we are not bothered about giving them oxygen. What we are bothered about is keeping their airway open. They are having large tongue and lot of fat in this area, so the tongue can easily fall backward and it can cause obstruction of the airway. So you want to prevent that obstruction of the airway, and you want to keep this airway open. You want the tongue to get pushed further. So in that case we use the continuous positive airway pressure or BiPAP machine. It gives positive pressure to keep the tongue away from the obstruction of the airway. Alright, so that is how we use a CPAP or a BiPAP machine, specifically used in obese patients who have obstructive sleep apnea. Alright, okay, next question. Ved is an intern walking at Marine Drive and he sees a man unconscious and unresponsive. He checks his pulse but cannot feel it. He also cannot see any respiratory movements. He calls an ambulance. The man also has some secretions around his mouth. Meanwhile, what should Ved do? Start mouth-to-mouth respiration, wait till help arrives, give a cardiac thump, or start chest compressions. What should we do in this situation? Okay, all right. So, absolutely correct. Whenever you have the situation of CPR, what is the first thing that you do? The first thing that you will do is verify scene safety. Okay, वो option तो इधर दिया ही नहीं है of verifying scene safety. Now, if your scene is safe, the next thing that you will go for is you will check for response. Okay, so already they have given you over here patient is unresponsive. Okay, next thing you will do is call for help. So, will you call for help over here? Yes, he has called an ambulance, so he has called for help. Next thing you will do is check the pulse and check the respiration. Okay, so cannot see any respiratory movements, checks the pulse but cannot feel it. And the next thing you do is start CPR. Now, problem with CPR is that there are secretions around his mouth. So maybe he is not comfortable giving mouth-to-mouth resuscitation in this patient. Imagine if there is secretions, vomitus, how will you put your mouth to that person's mouth and give rescue breaths, correct? So if he is not comfortable giving respiration, at least he should give chest compression. So at least he can start chest compression, so that will make the blood from the left ventricle go everywhere into the systemic circulation and it will help in circulating the blood. Okay, so that is what should be done in this case. You should give chest compression in this patient. Alright, okay. Now from these three pictures, first of all tell me what are these three pictures and then identify the disease that I am trying to show you in this picture. Identify these three pictures and then tell me what exactly do you see in them. Okay, Staphylococcus is saying acromegaly. Anyone else? Okay, absolutely correct. So if you look, this man is extremely short and this man is extremely tall. Now let's have a look at the fingers. So the fingers are spider-like, thin spider-like. Okay, so this is nothing but arachnodactyly. And what are you seeing over here? Sorry, what do you see over here? Yes, so tall height, arachnodactyly and high arched palate. High arched palate, all three of them are seen in nothing but acromegaly. Okay, so what is acromegaly? Acromegaly is nothing but excessive GH secretion from the pituitary, correct? Excessive growth hormone secretion from the pituitary. Alright, moving on to our next question. During a CT pulmonary angiography with contrast in the radiology department, a patient develops severe hypotension, bronchospasm and cyanosis. Which one of the following drugs should be used for treatment? Atropine, aminophylline, dopamine or adrenaline? Yes, waiting for a few more of you all to answer and then we can go ahead. Okay, absolutely correct. So what is this? This is nothing but contrast anaphylaxis. Okay, so you have given contrast to this patient and the patient has had anaphylaxis. So the patient has developed hypotension, bronchospasm, cyanosis. All three of them are due to excessive histamine release from the mast cells. And that is why you are having this contrast anaphylaxis. So what is the drug of choice for anaphylaxis? It is nothing but adrenaline. There is no other drug of choice, only adrenaline is a drug of choice in case of anaphylaxis. Okay, next question. A 4-year-old child is intubated by a pediatric resident by direct laryngoscopy. The professor asks him to check the depth of insertion of the tube by the formula given. Which formula should the resident be referring to? So what are they asking you? They are asking you for depth of insertion of endotracheal tube in a child. How deep should you intubate the child so that it stays in the trachea itself, it does not go into the bronchus. See, this is your trachea, these are your bronchi. Okay, sometimes when you put the endotracheal tube too deep, it may go into one of the bronchi, so it may cause endobronchial intubation and the other lung will collapse. So you want to avoid this, you want to make sure the tube ends over here in the trachea itself. So for that there is a formula to check how much deep do you want to put the tube. So what is the formula? H upon 2 plus 8, H upon 2 plus 10, H upon 2 plus 12 or H upon 2 plus 16. Sorry, I'm really sorry you guys are not able to see the picture. It's here. So what is the formula? Robin is saying answer is D, H upon 2 plus 16. Any other answers? Alright, Staphylococcus is saying B, H upon 2 plus 10. Do we have any other answers? C. Alright, so we have everyone, A, B, C, D, all answers are there. Okay, so depth of insertion of tube in a child, remember, is given by the formula H upon 2 plus 12. Okay, so suppose I have a 6-year-old child, so 6 upon 2 plus 12, so that becomes 15 centimeter. So this is how deep I will insert the tube. The other way of calculating is the size of the tube. Okay, so this is one of the other formulae that you need to know in pediatrics. How do you calculate the size of the endotracheal tube? So it is H upon 4 plus 4.5. Okay, so in this child, suppose it is a 6-year-old child, I will put 6 upon 4 plus 4.5. So that is roughly say size 6 endotracheal tube will be put. Alright, so this is the two formulae that you need to know in pediatrics. One is depth of insertion of endotracheal tube and one is size of the endotracheal tube. Alright, okay, moving on to our next question. So now you have intubated this child, okay, and after intubation you take this X-ray. What will be the next step in this case? Reposition the tube, continue ventilation in the patient, call for help or needle in the second intercostal space. Tell me the reason and why. Okay, Staphylococcus is saying you'll reposition the tube. Anjana is saying single lung ventilation. Any other answers? Okay, so where exactly is your tube, guys? You can see in the X-ray where exactly is the tube. Yes, so in the tube it is visible over here. As you can see, the tube is going into the right main bronchus. Okay, so the tube is going into the right main bronchus and it is ventilating only the right side lung. So right lung is ventilated, left lung is absolutely collapsed, and that's why it's looking like a whiteout. So where is your tube present? It is present on the right endobronchial intubation. You have done a right endobronchial intubation. Alright, so what do you do in this case? Nothing, just withdraw the tube. Once you withdraw the tube and the tube comes up till here, then you can ventilate both the lungs of the patient. Alright, so this is how we do it. So you'll have to reposition the tube for that case. Alright. A 3-year-old child has to be taken in for surgery. He is incessantly crying outside the operation theatre and refuses to come in. He does not allow IV to be secured outside the operation theatre. What is the most appropriate step that the resident should do? So you want to take a pediatric patient inside the OT. He's crying, he's howling, he's kicking. How do you take him inside the OT? What is the best way to induce this patient? Give intramuscular injection of midazolam and ketamine outside the OT. Take the patient inside with the parent and do inhalational induction with sevoflurane. Ask the parents to hold the child down and attempt to secure an IV, or send child to pediatric services for securing an IV. Okay, so all of you all are saying give IM injection of midazolam ketamine. Now tell me, how many of you have received an IM injection in your life? And tell me if the child will let me give him an IM injection or no. Isn't IM injection very painful? Alright, so intramuscular injections are extremely painful. The child is not allowing you to hold him also. So forget giving an injection. 100% is not going to allow. He is going to fight with you and maybe just bite you, okay, if you try to give him a IM injection. So the best thing to do, guys, is, I was trying to see if anyone has answered correctly, but none of you all have. So the best thing is you take the child inside with the parent. He will allow the parent to hold him. So tell the parent to hold him and come inside the OT. Then you hold the mask on the child's face and start sevoflurane. So when you start sevoflurane, the child starts inhaling the sevoflurane and he falls asleep. And once he falls asleep, then you can wake up. Then you can easily take the IV in the child. Okay. So we will do an inhalational induction with sevoflurane in this child, and just to make sure that he comes inside the OT easily, we will take him with the parent. Alright. Okay. A newborn child has tachypnea cyanosis and bowel sounds are heard in the chest. He shows the following X-ray. What is the probable diagnosis? Single lung syndrome, traumatic pneumothorax of delivery, congenital diaphragmatic hernia, or sigmoid volvulus. Very easy X-ray. I think मेरे सर से पूरा X-ray obstruct हो रहा है. So I'll just move a little bit so that you all can see the X-ray. Okay, Chakravarti is saying C, KGB is saying C. Any other answers? Staphylococcus angina, very good. All of you all are saying congenital diaphragmatic hernia. Absolutely correct. So you can see there are these loops of bowel that are coming up from the left side. There is a opening in the left diaphragm and the loops of bowel are there over here. You can see multiple air levels. Air fluid to nahi dikh raha, but air you can see in the bowel. And this entire lung, you can see there's an endotracheal tube over here, and the entire lung that is there is completely collapsed on the left side. On the right side, the heart has been pushed. So this child, because of the left lung collapse, is suffering from tachypnea cyanosis, and you can hear the bowel sounds in the chest because of the bowel that is there in the left lung. Okay, so what is your okay, KGB, if you start calling pediatrics for every IV that has to be taken in a child, they will stop picking up your calls because they are already very busy with their own admissions. So you're supposed to know as an anesthetist to put IV. In fact, you're supposed to be a specialist in putting IVs, not just in adults but also in pediatric patients. Okay, so this is a classic case of congenital diaphragmatic hernia, but what I want you guys to tell me is, what is this air? What is this air? And is that normal or abnormal? Oh, sorry, I don't think you can see it. देखो अभी और बताओ. What is this big gola of air that I am pointing towards? And is this normal or abnormal? अभी दिखाई दिया? Alright, so that is nothing but air in the fundic gas bubble. Okay, so that is your air in the fundus of the stomach. So that is also called as your fundic gas bubble. So your fundic gas bubble, normal air found in congenital diaphragmatic hernia. Okay, alright. So what would you do in this case of congenital diaphragmatic hernia? Intubate the patient, insert a Ryle's tube, decompress the stomach, do both A and B, intervention required only if there are symptoms. Very good. So your answer is, eventually you have to do both of them. Okay, both A and B has to be done. You have to intubate. You can already see that the tube is in situ because one side lung is completely collapsed. So you have to provide positive pressure ventilation and try to inflate that lung. Okay, especially the left lung. And the other thing you have to do is decompress the stomach. So how do you decompress the stomach? You just put a Ryle's tube and you decompress the stomach so that the rest of the bowel also enters back into the abdominal cavity. And then you can put a mesh on top of the diaphragm, and by putting a mesh on top of the diaphragm you can prevent the bowel from further entering into the thoracic cavity. Alright, so this is what you will do in this case. You will do both A and B. You will intubate as well as insert a Ryle's tube and decompress the stomach. Okay, moving on to our next question. A child is posted for elective surgery to correct posterior urethral valve. The mother was asked to follow starvation guidelines strictly. As the child was crying, she gave him half a glass of cow's milk. By how much time does the surgery need to be postponed? 2 hours, 4 hours, 6 hours or 8 hours? Okay, so most of you all are saying C, 6 hours. Alright, so quickly tell me, for clear liquids, what is our fasting time? For cow's milk, what is our fasting time? For breast milk, what is our fasting time? And for vada pav, what is our fasting time? Clear liquids is 2 hours. Very good. Cow's milk is 6 hours. Okay, so cow's milk, buffalo milk, tea, anything you want to have, it is 6 hours. For breast milk, for vada pav is 8 hours. Very good. So don't feed the child vada pav for sure before the surgery. And for breast milk, anyone? Tarun is saying breast milk 6 hours. No, that's wrong. 6 hours is for cow's milk, or if they say formula milk, okay, or if they say buffalo milk, goat milk, tea plus biscuit, that is a light meal. All these are 6 hours. Yes, breast milk is 4 hours. Breast milk is 4 hours. Alright. So this is how much you will give to the patient. Okay. A mother is concerned about her 6-month-old child's growth and development and wants to follow the milestone chart. What all should her child have achieved by now? Crawling and bisyllables, walking and cooing, monosyllables and supine to prone, bisyllables and pincer grasp. So since all of you all love discussing milestones and watching milestones, and I have a nice mnemonic video on milestones up on YouTube only. I've put the link for that milestones video. You will have fun and you will remember it also forever by just watching that mnemonic video. So tell me, what milestone should the child have achieved by 6 months of age? Yes, come on guys, all of you all should be able to answer this. बहुत pediatrics पढ़ते हो तुम लोग. I am very confident of that. Yes, absolutely right. So by 6 months of age, monosyllables and supine to prone should have come. Okay, monosyllables and supine to prone. Absolutely right. Okay. And the last question for this session, then we'll hopefully have a session in the night at around 10:30, 11. So while inserting a central venous catheter in the IJV in a tracheostomized patient, so patient is tracheostomized, okay? The patient gets severe hypotension, tachycardia, desaturation. What should be the immediate next step? ICD insertion, needle thoracocentesis in second intercostal space, needle thoracocentesis in fifth intercostal space, and intubation. Age of the patient is a 34-year-old male. Okay, so Chakravarti is saying C, staff is saying B, Anjana, staff, okay, staff has changed his answer from B to C. What is the reason for changing your answer? KGB Tarun are saying B. Okay, so what is the diagnosis over here? When you're putting a catheter in the IJV, what happens? The tip of your lung is here. So if the tip of your lung is here, what can you cause? You can cause pneumothorax, correct? So yes, with the IJV, pneumothorax is very much, while inserting the IJV central line, pneumothorax is very much possible. Now if you are getting severe hypotension, tachycardia, desaturation immediately, that means this is a tension pneumothorax. Okay, so you need to relieve this tension pneumothorax immediately. The best way to do this is by needle thoracocentesis. Needle thoracocentesis. Okay, now how do we do a needle thoracocentesis? There is only one way. You can do it by inserting a needle in the fifth intercostal space. This is for adults. Fifth intercostal space, mid axillary line, and for children it is in the second intercostal space, mid clavicular line for children. Okay, so your answer is C. Got it, guys? Alright, so with this we complete today's session. I hope you guys had fun discussing all these case-based syllables, case-based scenarios, and I will be taking another session in the night at 11 o'clock. So I'll see you guys at that time. Go ahead, have your dinner, and then we can have a little bit of revision post dinner at 11. And if you like the session, please don't forget to give a like to it, and I'll see you guys at 11 o'clock. Okay, bye bye, take care. The links to all of these sessions are here. Let's Crack NEET PG Telegram group.